invite Dr. MARIAN PAULY, a senior consultant from Giridhar Eye Hospital, for her talk on what's new in ptosis surgery. Over to you.
Yeah, good morning. I thank Dr. Indu for this. So, my topic is what's new in ptosis surgery. To be frank, actually nothing new, but we are doing some modifications. And more than that, ptosis is Richard Dorsby, he's the father of ptosis surgery. He has put across in his book as ptosis is hell. So that still holds true because even though whatever advances has come in the technique, each case is very, very, very unique and you have to customize for each cases. So my something which we are doing little differently because one is minimal incision levator advancement. It's called MILA because in ophthalmology you know MICS, MIVS, MIGS. So this will add to it MILA. This is actually not new. In the year 1999, Lucarelli, he's a very senior oculoplastic surgeon from US. He has published in American Journal of Ophthalmology Small Incision External Levator Repair. And after many years, in 2023, there are a few modifications, that is septum sparing minimally invasive technique for levator advancement surgery in aponeurotic ptosis. So this is not new, but what I'm doing now, I'll just show a small video.
Lid crease marking done. Traction sutures taken. An 8mm lid, crease incision done with the help of radiofrequency cautery. Orbicularis dissection is done. Suborbicularis dissection carried out in preseptal and pretarsal plane. Minimal pretarsal orbicularis is excised. Orbital septum is opened and retracted. LPS aponeurosis identified and sutured to the ptosis with non-absorbable single box suture with 6-0 proline after adjusting the lid height.
So after just take one suture through the tarsus to the levator aponeurosis and take the lid crease forming suture. So that's it. So this is a few patients. So first patient is actually she had undergone cataract surgery and she was eating cataract surgeon's head that she can't read. She had lots of watering, irritation, etc., etc. So if you see carefully, you can see her. She has got ptosis both eyes. And in the right eye, you can see the punctum is opposed. The problem is when the punctum is opposed, all these problems, functional NLDO leading to watering, irritation, etc. And she is 84 years, so I don't want to do any big surgery. So I just corrected with the Milla, both eyes. It's just like both eyes together, you will take only 15 minutes. So it's like more or less as fast as IOL surgery. It's like that in the left eye also. In the second patient, left eye I have operated. She had mild undercorrection which became all right later. So this is a very quick procedure. Here the advantage is very, very quick and fast recovery and similar success, more or less similar success as standard levator. But the disadvantage is sometimes if the suture is not really in the correct plane, you can get contour abnormalities. Similarly, overcorrection, which we have already saw. And if you're planning any adjunctive procedures like blepharoplasty, it will be difficult with MELA. So this is just to make the patient comfortable and will finish very fast. So now coming to the frontalis muscle flap. So again, frontalis muscle flap is also not very new. In this article by Song et al., he has already published in 1982. That is almost more than 20 years back. And in 2016, it's again in the plastic surgery journal that published a 10-year follow-up. So in that they have reported almost 20% undercorrections, etc. So now people like they wanted to see how it works in our ophthalmologist hands. So I'll just show a small video. Here the initial steps are the same. I'll just show only the important part. So suborbicularis. So suborbicularis dissection is done. Here we have to reach up to the orbital rim. And then you have to lift the frontalis muscle flap. So now the flap has already been raised. So this is the now I'm holding is the raised flap. Yeah. And I take a bite through the tarsus, levator and frontalis muscle flap to get so that it follow that contour and you should not get any peaking or any off the globe phenomenon, that is lid off the globe phenomenon. So this is the correction which you can get. So this is, you are taking a frontalis muscle. Basically, you are combining frontalis muscle as well as the orbicularis oculi muscle. So now look at the results. So initially, I was very enthusiastic in doing flap alone. So this is the one patient that again blepharophimosis. So I have operated both eyes. In the right eye, I have combined sling with muscle transfer, that is muscle flap, orbicularis, frontalis muscle flap, and the left eye sling alone. So if you look carefully, in the right eye, there is a good correction with a good crease, and the left eye little undercorrected. So this is one thing. Now what I have started using is combining frontalis sling with silicone and frontalis muscle flap. So this is another case. It was one of my first case, where I did only muscle flap. Even though initially he looked little okay, but 8 months, 1 year down the line, he had undercorrection. And now I am like, he's waiting for, actually I'm planning to revise with the regular frontalis sling. So it is, so this is another case. This patient I have operated 10 years before at the age of 4 years. Now she is 15 years and she just came for anything can be done. So here the sling has migrated little bit in the up. So for that I have done frontalis muscle flap, so that with flap alone the crease has improved and he got a good correction. So this is for the frontalis muscle flap. This is a very good procedure, but flap alone, I'm not very keen on doing it now. I'm combining both facial silicones with frontalis muscle flap, which gives very good result in almost all the cases. So now the third thing, no, this is also like something new which we are doing now. So there is an article published in 2019 OPRS, that is orbital septum fibrosis in congenital ptosis correlates with eyelid function, a clinical pathologic study. So here what they have studied is the laxity of the lid is reduced because of the fibrosis of the orbital septum. So in all the congenital ptosis surgeries, you know the pathology. I am excising. Usually we open the septum and do the levator resection. So what I'm doing is I'm excising a part of the orbital septum and then doing the surgery. The advantage is we'll get good correction, as well as the lag of thalmus is very, very less, practically zero, especially with the levator resections. So these are the three things which I want to highlight. One is Mila, and second is frontalis muscle flap, and third thing is excising the orbital septum. Thank you so much, and this is 2026 OPI. Thank you.
Thank you, Marian ma'am, for that great discussion.